Hi, this is Marie Drisick, physiotherapist at BC Children's Hospital. I'm happy to share a little bit about a project on behalf of my co-authors listed here, titled Healthcare Resource Utilization by Children with Cerebral Palsy. As many of you are likely aware, cerebral palsy is, of course, the most common cause of motor impairment among children, and it often is associated with a number of comorbidities or complications, which can require care, including medical and surgical subspecialists, rehabilitation and other paramedical professionals, and the use of assistive devices. Not very much is known, though, about how children with cerebral palsy utilize these resources and access them, particularly across the levels of the gross motor function classification system. This is, of course, the 5-level classification system of functional mobility, in which children at level 1 have mild impairments in areas of balance and coordination, and children at level 5 have higher levels of impairment and rely on wheeled mobility. A better understanding of the utilization of resources of children across these GMFCS levels may assist us in better supporting and caring for children with cerebral palsy and their families. The objective of this project then was to learn what health professional services and equipment are accessed by children with cerebral palsy and how these are funded. So caregivers of children from birth to 18 with a diagnosis of cerebral palsy, suspected cerebral palsy, or a similar condition associated with CP, attending a pediatric orthopedic clinic were approached and invited to participate in an anonymous electronic survey. Questions in the survey included those related to the child's function, as well as access to practitioner visits and equipment, as well as how these were funded over the preceding year. Demographic information was also collected. In total, 234 caregivers participated and completed the survey. The table at the right describes how the children of those caregivers were classified across GMFCS levels. So there were 63 children at GMFCS level 1, 56 at GMFCS level 2, 23 at 3, 38 at 4, and 50 at level 5. The average age of children was just over 9 years, and caregivers, the average age was 41 years. Slightly more male children were included, the caregivers of more male children, in keeping with our understanding of the distribution of children with cerebral palsy. And while children were required to have either a diagnosis of cerebral palsy or a suspected diagnosis, or diagnosis or condition often associated with cerebral palsy, less than 3/4 of caregivers identified their child as actually having a diagnosis of cerebral palsy. This slide shows a table that presents the number of hospital admissions and emergency room visits reported by caregivers across children of different GMFCS levels. We can see that there's a general increasing trend, particularly with hospital admission rates reported by caregivers, with children at GMFCS level 5 having caregivers, over 50% of caregivers reporting their child having been admitted to hospital over the preceding year. And of those children admitted, they had on average just under 5 admissions reported to hospital. This is over double of the number of caregivers in GMFCS level, of children in GMFCS level 1 reporting an admission to hospital. Emergency room visits also showed significantly higher percentage of caregivers of children at GMFCS level 5 as compared with those at GMFCS level 1 reporting an admission visit to the emergency room. As we can see, though, there was a higher overall mean number of visits for children at GMFCS level 1 compared to those at GMFCS level 5, of those reporting to have visited the emergency room. The next table presents the total number of ambulatory annual visits reported by caregivers, both for medical and paramedical professionals. Here across the top section, we can see combined visits to both groups of providers, both in total number of mean visits as well as the mean number of professionals seen over the course of the year. We can see here that the highest number of visits was reported by caregivers of children at GMFCS level 5, with over 100 visits reported over the course of that year. That's a third of a year nearly, in which every day there was a visit to either a medical or paramedical professional. the average number of professionals seen was just under 10. This is in contrast to those children at GMSS level 1 whose caregivers reported an average of 45 visits per year to a mean number of professionals of just over 7. When we compare medical visits versus paramedical visits, we can see that there was a significantly higher number of paramedical visits reported by children, particularly at GMSCS level 5, as compared to those those for medical visits. And this was consistent across GMFCS levels. Over the entire group, however, there was an average of 78.8 visits, with an average of 8.9 medical and paramedical professionals attended over the previous year. If we look more specifically at PT and OT visits, here we found that the highest number of actual visits to physio was reported by caregivers of children at GMSCS level 3 at just over 30 visits annually. When it came to OT, it was children at GMSCS level 4 whose caregivers reported the highest number of annual visits, with just over 20 visits reported in the preceding year. Across all children, 71% of caregivers reported their child seeing a physiotherapist over the previous year, and 71%, in fact, actually also reported their child seeing an occupational therapist. Here we begin looking at funding for services and equipment, beginning with funding specifically for PT and OT. While we looked at and considered funding across GMSCS levels, we also considered funding by age groups, looking at children at preschool age, elementary school age, and high school age. Funding for PT was primarily accessed through government funding, with over 3/4 of caregivers reporting accessing services or funding for PT specifically through this source, while less than 20% reported using private insurance for funding for PT. In spite of this, 23% of caregivers reported having to pay out of pocket for PT, while 7% of caregivers reported paying out of pocket for OT. Charity funding was also accessed by 5% of caregivers for PT as well as for OT. When considering by age groups, it was evident a greater reliance on government funding was reported among caregivers of children of preschool age compared to those at school age. When we looked at funding for equipment, we began by looking at the total number of pieces reported to be accessed across the entire group. And on average, it was found that caregivers reported their child accessing 2.5 pieces of equipment. Looking specifically at GMSCS levels, this increased slightly as we moved towards children at GMSCS level 5, where an average of 4.2 pieces of equipment were reported to be accessed. Looking at the graph in the slide here, we see presented the various sources of funding that was accessed by caregivers for funding those pieces of equipment. We can see here that looking at the GMSCS levels 1 and 2 towards the left of the graph, that the blue bars are shorter, so indicating there was a lower level of government funding accessed in these groups, whereas the green bars are a little bit higher, indicating that there was a higher level of reported self-pay among caregivers of children at GMSCS levels 1 and 2. Despite the higher level of government funding indicated in levels 3, 4, and 5, families indicated also having to self-pay at these levels as well, indicated by, again, the green bars to the right of the graph. Across all GMSCS levels, 22.6% of caregivers reported having to self-pay for leg braces or AFOs, and 10.3% of caregivers reported having to self-pay for wheelchairs. AFOs were found to be the most common piece of equipment accessed by children at GMSCS levels 1 to 3, and wheelchairs the most common for children at GMSCS levels 4 and 5. So in conclusion, there is an evident high use of resources in the group surveyed here. All GMSCS levels reported a high number of annual visits with healthcare providers, with a slight increasing number of visits in healthcare providers with increasing GMFCS level. Visit frequency may also vary within GMFCS levels, as we saw through the standard deviations. So there may be core groups within GMFCS levels that see a higher number of both visits or use of resources. Families of children across GMFCS levels were found to need to supplement the costs for both resources and equipment, suggesting a great need for additional funding for families and or potentially additional services. I'd just like to acknowledge the great contribution of Jamie Coates to this project overall, and thank you so much for listening.